Welcome, everybody. Our session will begin in just a few short minutes, and we'll get started. For those folks that are slowly rolling in, we're going to get started in just a few minutes, but we'd like to extend a big welcome to the Managing Chronic Pain After Treatment or with a Chronic Cancer session for the Your Life After Cancer conference. We'll give it another couple of minutes for a few more folks to roll in, and then we'll get started. See, we have somebody from Newfoundland joining us. Welcome. We have a hello in the chat from Montreal. Hello, Pascal. Oh, a hello from Sudbury, Ontario. Another person from Montreal, tuning in all across Canada. So for those of you who just rolled in, welcome. We will begin in 2 minutes our session on managing chronic pain after treatment and living with a chronic cancer. Got folks joining from BC, from Ontario, Vancouver Island, Winnipeg. Welcome, everybody. Excellent. And we'll get started in just one more minute as we have a few folks still rolling in. All right. Welcome, everybody, to the Your Life After Cancer conference. Throughout this week, you will be treated to the interactive presentations and expert-approved tools, tips, and recommendations to help you find your own path to a fulfilling life after blood cancer or with a chronic cancer. The Leukemia and Lymphoma Society of Canada is proud to introduce today's presentation titled Managing Chronic Pain After Treatment or with a Chronic Cancer. Effectively managing chronic pain after treatment or with a chronic cancer should take into consideration the physical, emotional, social, and spiritual parts of an individual. In this presentation, Jocelyn Brown, RN, MN, a pain and palliative care clinical nurse specialist, will share strategies for managing your pain. Allow me to begin by introducing myself. My name is Alexandra Clark, and I am the Community Services Lead for Ontario West at the Leukemia and Lymphoma Society of Canada. I will be the moderator and host of today's online event. Since there are many of you, we invite you to type your questions and comments into the question box of your Zoom webinar panel throughout the presentation. An LLSC staff member will monitor the questions, and I will read aloud some of your questions at the end of the presentation during the question and answer period. Today's presentation will be recorded. Therefore, you will be able to listen to it again on our website later. Next slide, please. At the LLSC, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their families. We offer support to those affected by a blood cancer throughout their blood cancer experience. Do not hesitate to contact the local community services lead in your region to learn more. Next slide, please. As you've surely heard, we launched our brand new website, bloodcancers.ca, last November. Our goal is to better serve our community and offer an improved experience. On our website, you will find all of our past webcasts, our podcast channel, information sheets, practical tools to help you navigate the blood cancer experience, and much more. Visit www.bloodcancers.ca for more information. Next slide, please. On our new website, you can also find a multitude of animated educational videos. The topics vary from information about specific types of blood cancers and recognized treatments. Most recently, we launched a series of videos on topics related to life after cancer and chronic cancers. The first two of this series are now available to watch on our website, Living with Chronic Cancer and the Fear of Recurrence. Next slide. It is now time to begin today's presentation, Managing Chronic Pain After Treatment or with a Chronic Cancer. It is my pleasure to introduce our speaker today, Jocelyn Brown. Jocelyn works as a pain and palliative care clinical nurse specialist at Princess Margaret Cancer Center. This role includes collaborating with the interdisciplinary team and hospitalized patients to develop patient symptom management plans, discuss advanced care planning, end-of-life care, goals of care, and provide psychosocial support. She also works in the cancer pain clinic with patients that are at home and experience pain before, during, or after their cancer treatments. She has been supporting people with cancer and cancer survivors as a clinical nurse specialist in pain and palliative care for over 13 years. She has been a nurse for over 17 years and loves providing a holistic approach, addressing not only the physical aspects of people suffering, but the emotional, social, and spiritual parts. Thank you for being here today, Jocelyn.
Thank you so much for having me, Alexandra. I'm so excited. It was so fun hearing about all the different places everyone is across the country, Vancouver to Newfoundland. So we've got the whole spectrum. Like Alexandra was saying, I've been working with patients with cancer, chronic cancer, treatment-related pain and the cancer pain clinic for many, many years now. And I work with patients with all different types of cancers, not just blood cancer. So, but I did actually start working when I was first a nurse. I worked in malignant hematology on the inpatient units, and I've come across a lot of patients over the years with complex pain related to their multiple myeloma or after having lymphoma, having chronic pain. So hopefully I can provide you today with a little bit of hope to get some new ideas potentially about how to manage your pain, and you might come away feeling a little bit more empowered and have a few more tools in your toolbox or strategies and things to bring back to your own team, ideas that you can bring back to your own team to improve your own pain management plan. So we're going to talk about how common pain is with cancer patients in general, some of the cancer and cancer treatment related pain syndromes, talk about different medications, and there's also lots of different options that don't include medications. So I really just wanted to highlight making sure that you contact your team if you have any specific questions. I know it's a chance for questions at the end, but obviously everyone has their own unique pain experience, and I want you to contact your healthcare team if you have any specific concerns related to your pain. And also I wanted to highlight hopefully you have specialized pain or palliative care clinics in your area. A lot of the palliative care clinics, people aren't aware they can follow people just for pain management or make suggestions to the family doctor, sort of a one-time consultation because they're experts in pain management, or might already be connected with a chronic pain clinic in your area. So there's lots of different options for being connected with the specialized pain management services. So really, we know, and you all know, you're living day to day with your own pain, but you really, pain is whatever a person says it is, and existing whenever they say it does. So you really need to find a team and someone on your team that's going to listen to you about your own unique pain experience. And having you feel heard about your pain experience is just so important to being able to um, emotionally feel supported through your pain experience, which is such a key piece to feel like all of the aspects of your pain are being addressed. So a lot of the times when I talk to patients that come to the cancer pain clinic, they feel like it's sort of the first time that everyone's listened to their whole story about their pain and how it's really impacting their life, their mood, their function. Um, they're trying to work, living with pain, it's distracting, having pain. And so making sure that you find a team that's going to listen to you and help out with all of those different aspects that impact your quality of life when you're living with chronic pain, and highlighting that pain, it's an unpleasant sensory and emotional experience. So just, I'm going to say it many times throughout the presentation, just acknowledging sort of the emotional work that needs to go into having an optimal pain management plan. With we know with chronic pain, it's best dealt with a three-pronged approach, and we can talk about medications or the pharmacological piece as one of those prongs, and then psychological support as another prong, and then the physiotherapy is the third that we can sort of think of. So if you have one of those pieces missing in your pain management plan, then you can add that piece to sort of optimize things. So I talk to patients about that a lot, making sure their mood is optimized as well. And I know when you're living with cancer, chronic cancer, living or you've or you've previously had cancer, there's just emotional work to do, and hopefully you're connected with um, a team that can help support you through that. So how common is pain? 30 to 50% of people with cancer experience treatment-related pain, and then 70 to 90% of people with advanced cancer experience pain. 35% of cancer survivors live with chronic pain, so that's a lot of people living with chronic pain. And then there's high impact chronic pain, which means that pain limits life or work activities on most days or every day within the past 6 months. And unfortunately, pain remains one of the most poorly assessed and treated symptoms. So it's very common, and we have to do a better job about treating it. So pain, we have to think of pain as not just most of the time people are just focusing on the physical part of the pain, but we also need to pay attention to and help support and acknowledge the emotional part of the pain, the anxiety and the fear. We do know that some of you may have heard of the gate control theory of pain. So this is the gate control theory of pain is a process where there's the way that the pain travels to the brain. There's a gate, and we have to try and keep that gate closed so that the pain signals aren't traveling to the brain. And medications can help close that gate, and different things that non-pharmacological things can help close that gate. But we also know that when you're experiencing stress and anxiety and fear, that gate stays open. So they've done lots of studies and tested people that are under more stress, and they experience pain more intensely. So and I'm sure I just was talking to a patient the other day, and she was reviewing about how she's had so much more stress in her life, and she's had a huge pain flare, and she was very worried about fear of recurrence, but she's going to have scans done, but it's just lots of things have been happening in her life. So we just talked about how stress is impacting her pain experience and the importance of dealing with that stress, and hopefully then her pain will get under better control. So your mood, your past experiences, and your expectations can all change the way pain is interpreted by your brain. So if you've had a bad experience with, for example, a bone marrow biopsy or a lumbar puncture before, or something, then when you go in for the next one, you might anticipate that you're going to be having a lot of pain again, and then actually feel more pain. And there's a concept, some of you may have heard of, something called the placebo effect. There's actually something also called the nocebo effect, which means that even just talking about pain can trigger your brain to experience pain. So if you are talking about headaches or any sort of pain, it can sort of trigger your body to sort of start feeling that pain. So they actually they encourage healthcare professionals to say things like, how comfortable are you feeling, rather than how is your pain feeling, so that those words aren't triggering your experience. So it's just quite fascinating how the brain processes pain in such a complex way. So total pain, and Alexandra mentioned this in her introduction, it's important to acknowledge when dealing with chronic pain is all of the suffering that's involved and how it really impacts so many different aspects of the quality of life, and dealing with not just the physical but the psychological, social, spiritual, and practical struggles that are involved when living with pain. So really exploring the meaning behind the pain. I had a patient and she had cancer in her bones, and when she would rate her pain on a scale of 0 to 10, she would say it was 3, but you could tell there was just so much more suffering behind that, because, you'd think 3, oh, that's mild pain, her pain is under control. But her pain meant to her that, she wasn't able to play with her children that the way she wanted to. It was sort of the distraction for her, and reminding her that she had cancer. So that's where the suffering came in. So exploring what the meaning behind the pain for you is, as well, is very important. This is just a more of a diagram around total pain, just describing it a bit more. So you can see how the total pain experience um, can impact you psychologically, developing depression, contributing to depression, anxiety, anger. So keeping all of these things in mind when you're treating your pain is important, to have a holistic approach with your pain management, dealing with social issues that you may be having, maybe addressing some spiritual struggles that you're having, can also can altogether contribute to optimizing your pain management plan. So I know when you're talking about your pain, it's really tricky to talk to your healthcare providers about your pain. We have to communicate some ways. So we use the brief pain inventory in our pain clinic, which really asks different things about the scale of 0 to 10, which I know it feels like it sort of minimizes your pain experience when you have to pick a number, and the number could be changing from second to second, but it's just really a communication tool to get some sort of sense as to if the pain is getting any better when different treatments are implemented. But sometimes the number stays the same. Patients will say to me, my pain is always an 8 out of 10, it never changes. It's just always an 8 or 10. But when you ask the other questions, are you sleeping better, is your mood better? Are you doing more things? Are you getting out more? And those things are improving. So from a functional or mood perspective, things are improving depending on what interventions we've started. So maybe the 0 to 10 scale is the same, but the sleep has improved, and you're getting out for a few more walks. And those are the indicators that positive outcomes are happening. And also just talking about what medications. So those are just a few example questions. About, your team needs to know what medications you're on and what you've been on before and what has helped. So if you haven't had a really thorough pain assessment, going over everything, and it takes a long time to sort of tease through everything that's worked, not worked, what's going on, and especially if you've had chronic pain for a long time, it could be years of history of trialing this, trialing that, and figuring out the right routine when it comes to medications and all the different things that you're implementing into your pain management plan. So what is your pain diagnosis? So it's really important that you actually understand why you're having your pain, and you have a pain diagnosis, whether it be, it's muscle aches and pains, or whether you have nerve pain. But you have to know sort of what is the reason behind your pain. Your team might say, oh, you have, chronic neuropathic pain from a surgery you had, or you have chronic pain, chemotherapy-induced peripheral neuropathy. So you need sort of a diagnosis to know what exactly you're dealing with so you can get on the proper treatment plan. So to come up with a diagnosis, the team should be asking you different questions, and it's really sort of asking lots of questions to figure out what the diagnosis is. And these different experiences and sensations that you have can help identify what type of pain that you're having. So if some of them cut over, like throbbing pain can be sort of nerve pain or tissue pain. But most of the time, if you have bone and tissue and organ related pain, most people say it will be more aching, more and worse with movement. And then with nerve pain, it's usually that classic burning, numbness, tingling, pins and needles, and those electric shock and shooting pains that you experience. So it's that's why we're asking for those qualities of pain when you come to see your team, so we can figure out and diagnose what type of pain that you're having and because there's different treatments for these different types of pain. So consequences of untreated acute pain, just it can change your actual vital signs. Your heart rate can go up, can disturb your sleep, and then you can develop chronic pain. Some of you may be in that. Some of that may have happened to some of you where you had some acute pain that wasn't treated, and that developed into chronic pain. And consequences of untreated chronic pain. I'm sure many of you are living through this. Sort of all the physical experiences of fatigue. Patients always tell me how tired they are because they're not sleeping because of the pain, and it's just impacting so many different aspects of their life, limiting activities and impacting mood, as also impacting the different social activities that you can do. You can feel very isolated. And also it can impact a person's ability to focus and decrease concentration. I was just talking to a patient recently, and he was just telling me just about how distracting it is to have pain, and how it's really impacting just his ability to go about his day-to-day activities, because he just feels so overwhelmed by his pain all of the time. So you can get pain from different reasons. You can have pain when you've had cancer or living with cancer, or so that you can have pain that is from the tumor, or you can have a fracture. Um, the cancer can block an organ or a tube in the body. You can have a bowel obstruction. You can obviously get pain from different treatments, chemotherapy, and I'll talk a little bit more about chemotherapy-induced peripheral neuropathy. You can have pain from radiation, surgery, and obviously all the different acute pains you can have from the different tests and treatments. Some chronic pain that people can develop, which is quite common with patients with ALL, is avascular necrosis, which is secondary to all of the treatment with steroids that's required for that treatment protocol. And oftentimes people with blood cancers, because their immune system is compromised, you can develop shingles. And unfortunately, I've seen patients with refractory shingles pain, and it's taken a long time, even years, to go through all the different medication trials very carefully to find a good option for their shingles pain. And also patients with blood cancers can often get infection related pain. I already mentioned the chemotherapy induced peripheral neuropathy. Um, and it's that classic stocking and glove pattern. So your hands and your feet, it can go up. For some patients, it can go up higher into their wrists and ankles, and even into the legs and arms. And unfortunately, it can be it can cause not just numbness and tingling, but often patients will say burning, even cramping. It can cause decreased sensation in the feet, so it makes you at risk for having falls or tripping. And it's really important to get on appropriate treatment early for the chemotherapy-induced peripheral neuropathy. The number one treatment for that is duloxetine. The other name is Cymbalta. That's a medication that's in the category of antidepressants, but they commonly patients will be on gabapentin or pregabalin, but they've done studies and duloxetine is shows much higher results when treating this type of pain. Arthralgias and myalgias uh, um, are also a type of cancer and cancer treatment related pain. Oftentimes patients can use duloxetine as well for this, the same medication that's used for the chemotherapy-induced peripheral neuropathy. I've seen many patients that it helps out, but NSAIDs can be an option, but it also depends on obviously your kidney function and all different factors. If people are on certain treatments, it might be contraindicated. So again, just highlighting, if you see anything in this presentation, just obviously you're making sure that you're checking in with your healthcare team before taking any new medications. There is some evidence to say that acupuncture can help this type of pain as well. There's so many different types of treatments, and that's the trouble with trying to find your optimal pain management plan. Is it's a lot of trialing different medications, different treatment options. Maybe acupuncture work for someone and then it doesn't work for you. So it takes a lot of patience to get through all of these different options and figure out which combination of these therapies is going to be best for you. So avascular necrosis, I mentioned that we talked about this. It's the thinning of the bone. Unfortunately, if you have severe avascular necrosis, you might need to have a hip replacement or shoulder replacement or whichever joint is affected by the avascular necrosis, which is a disruption in the blood supply to the bone, because the bone basically loses the blood supply and then it becomes necrotic, which means the bone tissue dies and it needs to be, you need to have a new hip or a new shoulder, whatever. But oftentimes they try and sort of delay that surgery until it's absolutely necessary. A lot of patients that I follow that have AVN, they've had consultations with orthopedics and they're working on just sort of keeping an eye on things and then deciding when to do a hip replacement or a shoulder replacement, when that would be optimal. But managing with medications, physio, there can also be some interventional blocks that can be helpful as well. So surgery can obviously cause pain. 1 in 5 people develop chronic pain from surgery, and the best way to prevent developing chronic pain from surgery is to have good post-op pain management and really be on nerve pain medications. And I'll talk more about those nerve pain medication options in a few minutes, and focusing on treating anxiety and depression as well. Radiation can cause pain and people can develop chronic pain from radiation treatment, such as plexopathies, and that can even develop many years after having radiation. So breakthrough pain, most people living with pain live with breakthrough pain as well. So it's just a pain that sort of breaks through on top of the baseline when the baseline pain is controlled. So it depends on if your breakthrough pain is caused from nerve pain, then you might need to optimize your nerve pain medication routine. Or if your breakthrough pain is caused by tissue pain, you might need to optimize some other medications like acetaminophen or your opioids. But we do know with chronic, when you're living with chronic non-cancer pain, which is if you don't have any cancer anymore, then opioids, ramping up the opioids isn't the answer, and I'll talk more about that in a bit. So this is a really important message to get across today. It's really, if your pain is changing, you really need to communicate with your healthcare team. If you have any new pain, any sort of change in the chronic pain that you've had, and it just a check-in with them just to let them know what's going on. You might get regular flares on your own and sort of know yourself and know, oh, this is, I overdid it on the weekend, and now, this is my regular flare that I always get after I overdo it. And sort of your own pattern. But if you're starting to experience something new outside of your own pattern of familiar pain, then you definitely need to let your healthcare team know. And a lot of people that I speak to in the cancer and cancer treatment related pain clinic, they're really concerned that any sort of change in their pain might mean that they have something going on with their cancer. So it's only, as you can see, it's only one of lots of different things that could be going on. So communicating to your team and figuring out and actually getting that pain diagnosis again, and reevaluating things and to see if maybe the medication that you are on, it's not working anymore. I've seen that just patients will say, you know what, this worked for a while for me and now it doesn't work anymore. Maybe there's something going on. Maybe you have some sort of infection that's contributing to your pain. There's lots of different reasons why your pain could be changing. So I think this is really important for y'all to see. It's this idea of having, if you're living with chronic pain and you haven't come across this before, it's really important to understand the idea of how you get into sort of having this pain centered life. And a lot of patients that I talk to, we follow them for years in the pain clinic, and it's taken them sort of after their treatment finishes, they have pain, develops into chronic pain, and then it takes them a really long time to sort of adjust to the new normal of living with chronic pain. And I've had one patient specifically say, you know what, my pain is exactly the same as it was a year ago. I still have the pain, but now I've just learned how to live my life with the pain. This is my new normal. I've adjusted. I accept that I have chronic pain, and after going through all the different options and coming up with the best sort of routine with things, there there's still pain there. Getting down to a 0 to 10 all the time isn't a reality for people living with chronic pain. So just that sort of acceptance, and there's something that is offered, that you might have heard of, the acceptance and commitment therapy. It's specifically related, can be specifically targeted for patients trying to learn how to sort of accept the fact that they're living with chronic pain. So you can see how you can get into the cycle here of having an injury, develop persistent pain, and then um, your pain isn't adequately managed, and then your muscles get tight and weak, and then you have fear and grief, so you reduce your activity and you get isolated and more depressed, and you're having sleep problems. So everything sort of cycles into developing this pain-centered life. So you have the pain and you isolate yourself, and then you even get more deconditioned. Because remember, I mentioned having physiotherapy, and a lot of patients with chronic pain need to be on different strengthening and conditioning protocols, because the cancer treatment has sort of deconditioned, and then to get back to sort of a point where you're feeling stronger and able to function and go about your daily activities, and not have this pain-centered life is so important. We want to get back on to going from a pain-centered life over to a function-centered life. And I mentioned education and pain management is really important. I have some slides at the end which highlight some resources that you can access for educating yourself. And in chronic pain, we often talk about chronic pain self-management strategies, and just the importance of education and learning about your pain, learning about different skills about how to live with pain. So getting back into having more increased activity and improving your social life, and can improve your confidence and your motivation to sort of live in a function-centered life rather than living in a pain-centered life. So the pain treatment and the intervention obviously depends on the type of pain. So I keep mentioning that you need to know what you're dealing with and know what your pain diagnosis and the different treatments I'm going to go over in the next few slides. So there's many people involved with your, there could be lots of different people on your team. All of these people that I've listed here, hopefully, if you don't feel like you have an optimal pain management plan right now, you can connect with your own palliative care team or pain clinic to help manage your pain. But there's so many people that can be involved to deal with the different types of, or to optimize your pain management plan. So radiation therapy, chemotherapy, surgery, these are all different things that can help when you're going through cancer, but maybe you've developed some chronic lower back pain and you could potentially need some sort of intervention, um, like a surgery to help with your chronic back pain. So medications, just I've mentioned it already that it's always a trial. Some people ask me, just give me the best, medication. There's no best medication. We don't really know what's going to work. There's definitely guidelines. There's guidelines around which medications work best for different types of nerve pain. I know I mentioned for chemotherapy-induced peripheral neuropathy, the studies have showed that using duloxetine is the best choice. So there's different studies and different guidelines, but there's definitely no magic pill that works for everyone. We can sort of follow our guidelines, follow our standards, start with what we know usually has the best outcome, but sometimes the outcome for a medication might be just a 20% reduction in your pain, which can be a big win for some medications. We're not always looking for 100% pain relief. We're just looking for, if we're adding in different aspects of your pain management plan, maybe maybe a massage helps a little bit, maybe this medication helps a little bit, maybe the physio helps a little bit, maybe doing a bit of mindfulness. So using all the different aspects of the medication and the non-pharmacological things to sort of make sure you have you're targeting your pain from different angles. Make sure you understand your prescriptions, and then also some of the pain medications, they can take weeks and weeks to really take effect. I often have patients and just having to make to remind them, you're not going to take your nortriptyline or whatever, for example, the pain medication that we start you on, and take it once or twice, and you're going to notice a difference. We have to start low, like start on a very low dose of the medications, and then increase the dose over many, many weeks to get up to sort of a therapeutic dose that we expect to work. Because if we started at sort of a high dose on a lot of these medications, the side effects would be too intolerable. So it can be weeks and weeks of waiting to see. And after titrating up the medication to the point where you're tolerating the medication with minimal side effects, then we can sort of make sure that you've had a good trial of the medication and gotten up. If you've only taken a low dose of a medication and you stop taking it, then that's not a good trial. There's only so many medications that we can use for pain, so we want to make sure we have a good trial of each medication that you tolerate. So opioids are very, very common if you're living with chronic pain, and you don't have cancer, and if you don't physically have cancer anymore in your body, then the ramping up the opioids isn't the answer. They've done lots of studies, and going over 90 milligrams of morphine a day doesn't show any more benefit. You can just keep increasing, and there's no more benefit. You just end up developing a lot of adverse effects, and it can become very problematic. So, but if you're living with chronic cancer, you might need to be on differing doses of opioids, and it's and just highlighting, I just listed the strongest to the weakest. So there's fentanyl patches, which in one little fentanyl patch is 100, a 25 microgram fentanyl patch is 100. It's equivalent to 100 milligrams of morphine. So a lot of people I had one patient, they called it their little sticker. And I'm like, it's not just a little sticker, it's a very, very strong medication that you have to be very careful with. So most commonly people are on hydromorphone or Percocet or morphine. We are using a lot more Trimacet and Tramadol, and I do find family physicians tend to use that medication as well. It's a weaker opioid, but it's sort of like an opioid mixed with an antidepressant, which can help close that gate both and target closing that gate from two different angles. And when we talk about using antidepressants in for chronic and cancer treatment related pain, it's not necessarily because you might even say you have absolutely no, you're not depressed, but the antidepressant category of medications works to close that gate to the brain for, and so we think of them as pain medications, and oftentimes with depression, they're used in higher doses. So these are other types of medications I mentioned. This is just a list of all different types of medications. It might not even be um, comprehensive, but it's all the mostly common medications that types of medications that we use for our cancer patients. So I mentioned the antidepressants, and just some examples there: anticonvulsants, anxiolytics. There's muscle relaxants, and you might be on one medication, you might be on two, you might be on three, but it's important sort of not to make too many changes at once, never starting two medications at the same time, always being very careful uh, when you do have multiple different medications to make sure that there's no interactions and things like that. So there's lots of different, if you have spasms, you might need to be on medication like baclofen, and then if you have some nerve pain, you might need to be on a nerve pain medication. So you have to, all these different medications can target different aspects of your pain. Medical cannabis is very, very popular. We actually don't specifically prescribe cannabis at our pain clinic, but we refer patients out to the medical cannabis clinics because it's can be very complicated. There's different balances of the THC and the CBD. We do prescribe Nabilone though, which is a synthetic cannabis, and it's fourth line evidence for treating chronic neuropathic pain. It can also, a lot of the patients that I have that are on cannabis, they say it helps sleep, it helps mood, it helps other things, appetite. So it sort of can help with different aspects. And they might say, I'm not sure if it's really helping with my pain, but it's improving my quality of life from these aspects where as I'm sleeping a bit better and I feel like I can deal with my pain better. So non-pharmacological treatments, there's so many different options. I think it's really important if you haven't had a good assessment by physiotherapy. We're lucky here at Princess Margaret, we have the Cancer Rehabilitation and Survivorship clinic. So patients can go and get assessed by a physiatrist, meet with PT and OT, and get on a good routine for their physiotherapy and rehabilitation needs if needed. And then there's lots of different, it's just really important aspect of your overall pain management to have a good physiotherapy plan as well. So non-pharmacological treatments, a lot of you may already use heat and cold, and I always just remind people, maybe you've taken your PRN opioid for your breakthrough pain, and then you're just waiting for it to kick in. Maybe you just use a cold compress or something like that, because I didn't mention it when I had the opioid slide up, but there's a lot of opioids. You might be on a long acting opioid, and then you have a short acting opioid for breakthrough pain. And the short acting opioids usually take about 30 minutes to an hour to kick in when you're taking a pill form of them. And so if you need a little bit of relief before that, you can try heat or cold, or just try it any time that you might feel like you might need something, some extra pain relief. So massage can be an option. And unfortunately, a lot of these things, they might they're not always free. So I have a lot of patients, they're like, well, how do you access massage? And, if you don't have good benefits to cover massage, it can be tricky. I have a patient, she actually accesses massage through her local hospice. They offer those kind of programs. So you might have to do access some programs through different organizations in your community. So it's like a piecemeal. I always find patients are going here, going there, going here, to sort of get the different pieces of their pain management plan in place. They're getting a massage. They might be going to the medical cannabis clinic. They might be coming to us. Then they're going to see their psychiatrist. So it's sort of all the different resources that they're accessing, and not in one place, which can be cumbersome. So what I just really wanted to mention, and you'll have these slides or access to the video afterwards. So I go over all the things, but I just wanted to highlight there's just a lot of different options and really just trying to see what works best for you. I had one patient and he said really the only thing that worked for him was his mindfulness meditation. He had horrible horrible pain in his jaw area. So it might be something that there is uh, um, a lot of different mindfulness meditation programs out there. Everything is online right now. I was even checking with the psychiatrist that runs them here at Princess Margaret, and she said they're not even having any in person yet. So they're more accessible now. The mindfulness based stress reduction programs are the ones that, and there are some programs that are specifically targeted for patients living with chronic pain. So you can ask around in your area and try and access those because it can be very helpful. Distraction, I always like to help to highlight that. And that's another way that you can close that gate of that pain signal going to your brain. I had one patient and he didn't feel pain when he was driving. That was just such a distraction for him that it actually just sort of completely closed his pain gate. And he said, if I'm having whatever pain he was having, he would go for a drive and then his pain would go away. So figuring out that's obviously you're not going to be able to just do that all the time, but figuring out what distraction things, what you really can get immersed in, that can distract you from your pain is really important. Make a list of things, and then when you're having your pain, just go through that list and try and figure out what's going to work for you. Um, Oh, it's 12:45. So non-pharmacological treatments, you can have nerve blocks, neuromodulation treatments. I work with two anesthesiologists. They review all patients to see if they're amenable for some sort of nerve block. You can ask your team about that. Sometimes it's a separate team, the anesthesiologist, or sometimes a separate team than with your regular team. But we offer nerve blocks here. And then just thinking of, I've already highlighted sort of addressing the psychological aspects, so learning skills, cognitive behavioral therapy, learning chronic pain self-management skills, how to focus not on that pain-focused life, but getting back to more of a function-centered life through something called cognitive behavioral therapy can be very helpful. Just a few more slides here. So questions to ask your healthcare team. Just maybe you weren't connected with a specialized pain team, and maybe that's an option for you. If you feel like you're living with too much pain on a day-to-day basis, it could be helpful to get an assessment. What are the options for your pain medication? What are the options for non-pharmacological things and trying to figure out what sort of resources you have in your area, and what's the natural history of your pain? Are you going to have to be? Patients always ask me, how long am I going to have this pain? Am I going to need to be on this medication forever? And sometimes the answer is yes, you might need to be on, but usually we try patients on their medication routine for a long time, and then eventually they might say, well, their pain might change and they might want to wean down on the medication a little bit just to see where things are at. So some good questions to ask your healthcare team. Also know if your pain is changing, who can you call? That's really important to know. So it's really important, I think, I've highlighted throughout this presentation just about targeting pain from a holistic approach. So coming at it and seeing, uh, how the pain is affecting your lifestyle, and making sure that you're not just taking pain medication, but also having setting some goals, eating healthy, trying to stay active, and also dealing with your mental health. There's lots of resources out there, including social workers, psychiatrists, psychologists, and that can be accessible. There can be a lot of emotional experiences that you've had throughout your cancer illness, and just making sure that you're talking to someone about that, because we know that when you're feeling stressed and anxious, you're going to feel your pain experience is not going to be, you're going to actually feel your pain more strongly. And we've gone over, I've highlighted there's lots of different medications. What are the right medications for you, and what's the right combination of medications that you can take, and beyond that combination of medications with having minimal amount of side effects as well. Sleep is really important. A lot of patients with chronic pain, they just don't sleep well. So they're actually one of the clinics here in Toronto. They actually have a sleep specialist that works right in the chronic pain clinic. So whether or not you need to go see a sleep specialist separately, or if your pain clinic or your family doctor is able to help you go over proper sleep hygiene or work on that sleep management plan as well, can contribute to your pain experience throughout the day. And also just communicating with your healthcare providers. I've highlighted that, if your pain is changing or if you have questions, there's, maybe you've been living with some pain for a while and you just think that there's no options, but asking, what are there options? Are there any other options that haven't been explored yet that you could trial? And making sure that your family, friends, loved ones, they sort of understand that you're living with chronic pain. I've had taken care of patients and they just say, my family doesn't understand. I have severe chronic pain all the time, and it's really making me um, not be able to do my day-to-day things. And people, family members will sometimes we have the family members come to the pain clinic as well to go over the plan as so that they understand and can support their loved ones better. So just in a summary, really you really need to get a diagnosis for what your pain is, and so that you can get on the most effective treatment plan. We have to deal with pain in a holistic approach, not just addressing the physical, but also figuring out uh, how the pain is impacting you emotionally, or even just what other things, going through cancer can be, a very traumatizing experience, and maybe you need to work through some of those things to help impact your mood. So coming at your pain management plan from a holistic approach is very important. And it's very individualized. Medications will work differently for different people. Acupuncture might work, might not work for you. So recognizing that everybody needs their own individual pain management plan. And I've said it before, it's really a trial, which takes a lot of patience for people to go through and recognize that they need to try different things and get through to have the best pain management plan. So just have some resources, and you guys will have this presentation. So these are different free resources, different resources across Canada that have information on pain management. So just wanted to provide you with some of those. There's some mindfulness apps and some different things, and a few books as well. Okay, so I think Alexander's going to manage the questions. Thank you so much for inviting me. I love speaking at these types of things, hoping people got a few different ideas about how to optimize their pain.
Thank you so much, Jocelyn, for sharing your expertise and insight with all of us today. We'll now move into the question and answer period of the conference presentation. And if you have not done so already, please be sure to use the question box in your Zoom webinar panel to type your questions. We are going to do our best to get to as many questions as possible, and any questions we don't do, we will be sure to follow up. So one of the questions live from our audience, what is the best way to advocate for yourself with your healthcare team when you're told there is nothing to do for pain or discomfort? Speaking about peripheral neuropathy specifically.
I mean, it's challenging if you've been seen by a specialized pain clinic. Hopefully, I'm not sure if you mean that your specialized pain clinic has told you there's no options. Maybe you have gone through all the options and they're encouraging you to just learn how to live with your pain. But if you haven't gone through all the options, different medications, there's acupuncture, trying all the different options. We have something called some people actually get something called like a spinal cord stimulator. So it's like neuromodulation technique. So you can go for an assessment with one of the centers that does that. I know I'm talking to people all across Canada, so it might mean some traveling to go to a center that offers that kind of thing. Actually, because they do offer that kind of thing in Canada now. Many years ago, I had a patient, she actually traveled to Rhode Island to go to a neuromodulation center there, and she did get quite a bit of relief from her from her peripheral neuropathy. So, and making sure, so I mean, it's just a matter of whether you've tried lots of different things and you've spoken to the experts in the specialized pain clinic. So if you feel like you haven't done that, then maybe there are some options. But we do have patients, and we've gone through all the options, and unfortunately, it's just a matter of learning how to live within your new normal as well. Um, and using some of those things like acceptance and commitment therapy and cognitive behavioral therapy and the chronic pain self-management techniques to learn how to live with your chronic pain if you've gone through everything, because there isn't always, unfortunately, an option to for some reason for some people to relieve the pain. But like I said, all the different things can help, like working on things like distraction and all those different mindfulness, trying to work on those kinds of things as well is really important.
Thank you so much for that answer. The next question comes from somebody who says they are 76 and they'd like to know the difference between general health issues and their diagnosis, such as Waldenstrom macroglobulinemia.
Oh gosh. Oh, do you mean like, if I'm not sure what you mean about in relation to pain? What does that?
Yeah, I think the question is saying, how do you know if the pain is related to
Oh,
general
I
health
see.
issues due to old age or
Oh
pain
yeah.
related to a
It's tricky.
diagnosis or
Yeah,
treatment?
it is really tricky. You have
Yeah.
to sort of, and you might actually need to go, you're 76 years old, you might need to go to like a geriatric, see a geriatric specialist. Everybody might need to sort of work together. Um, your blood cancer specialist with the geriatric specialist to sort of tease things out, whether or not we think it's caused, sometimes they might say, you know what, we've done all our assessments and we're not even sure. So sometimes there isn't an answer because lines can be blurred between, if you have other comorbidities like diabetes and that's contributed to some neuropathy, but many patients, and we know they have neuropathy pain and they also have diabetes. They might have a bit of chemotherapy induced neuropathy as well as diabetes neuropathy and things like that. So it's like you can have um, pain from, non-cancer related or non-blood cancer related things, as well as just other chronic conditions. So, getting just a really thorough assessment over those things about that is really important. And but sometimes you might not be able to get a clear answer if things are sort of overlapping and blurring like that.
Great, thank you so much. The next question comes from our audience live today. What is the best way to speak to your support network about your pain and discomfort or instability due to both when you look okay and they do not seem to understand your limitations?
Yeah, that's so hard. I really feel for you, because it's so hard when people don't really understand that, they just look at you and they see, oh, you look fine. Why aren't you just going about your day-to-day things? But just the feel, so I mean, everybody, knows their loved ones and their family and their friends, and how I can't say that there's one easy answer for that. It's just a lot of genuine communication and hopefully just you know they if there's someone specific, they might need to come and join in with your pain specialist appointment, and just normalizing that for them, saying, look, many people with live with chronic pain, and it really impacts my quality of life for this and this and this reason. So it is very challenging when you don't feel like the people in your circle really understand your pain experience. So connecting with, there might be support groups for people that have living with chronic pain, connecting with those people so you sort of get that empathy on that level for people that are really living with chronic pain, but just keeping the lines of communication open with your loved ones, and making sure that they understand. I don't know if there's any literature specifically targeted towards family members or loved ones of people with chronic pain. That's something maybe I would look into that. But it's really challenging. But normalizing it, and maybe they do need some information from your healthcare providers that, this is something that people often live with, and chronic pain is very common and can be very, very debilitating. And so I'm sorry you're going through that if that's your experience.
Absolutely. Thank you so much for that answer. The next question, this individual's lymphoma resulted in a spinal cord compression. They're hearing that nerves take a tremendously long time to repair themselves, but they're wondering if there's anything that they can do to speed up the nerve recovery.
Nothing that I know, nothing. No, there's no magic that I know of, that I've ever heard of. I've met many patients with I was actually thinking about that exact patient population before I came on this call, because I have met patients with spinal cord compression from lymphoma, unfortunately. And just making sure that you're on all of the right nerve pain medications, and it can be really, really complicated. And the right, maybe hopefully you've seen a physiatrist and done all that. I'm sure you have all that rehab stuff, but there's nothing that I'm aware of that can sort of, and I've dealt with lots of patients with nerve damage, nothing that I'm aware of that can speed up the recovery of the nerves, unfortunately.
Absolutely. Thank you for that answer. Next question is, how common is chronic pain after treatment?
I mean, I don't have any. I was looking for some statistics specifically for it's tricky because there's so many different types of blood cancers and everything like that. But I did have that one slide at the beginning that mentioned how common pain is uh, just in general for patients that are living with so 30 to 50. So after treatment, it says 35% of cancer survivors live with chronic pain. So, but a lot of people are living with chronic cancer. So, and have pain. So, so it seems like just a lot of people, based on these numbers, unfortunately, a lot of people either live with chronic pain and from their cancer. So I think we're lucky here at Princess Margaret to have, the whole palliative care team, and then our cancer treatment related pain team. We have anesthesiologists, we have physiatrists, everything like that. So lots of different people involved to help with this. But even so, the waiting lists are long. I know so many people that finally get to the pain clinic. They're like, well, I've been living with this pain for so long, and that kind of thing. So unfortunately, I know there's a huge gap in services availability around, getting specialized pain treatment. And if you're going into trying to get into like a regular chronic pain clinic in the community, not one that's not associated with a cancer center, it can be many, many, many months of waiting, and really, really complicated. Um, so unfortunately, I think we definitely need and family doctors are also, it's challenging for family doctors to manage this as well. A lot of family doctors, it's very time consuming. Remember I was mentioning all the medication trials. It takes a lot of, and I'm the nurse in the clinic, so I do all the follow up around, is this medication working, all that kind of thing. So I'm talking to patients week to week to week to see how things are going with their treatment. But family doctors or other healthcare providers, they don't have that. It's very resource intensive, time intensive to sort of, oh, did that really work? Is it helping? What's happening, and following up. Sometimes, you might just get a medication and it's like, oh, here you go, fly with it and go with it. And it's not really the close follow up is lacking. So it's really, I think we need to do a lot better with our pain management programs, especially for cancer and cancer treatment related pain, because we know that it's unique, it's very challenging to manage, and there's a lot of people living with it, and we're not doing a great job. We have, it was actually a doctor that dealt with breast cancer that started this pain clinic at Princess Margaret, because so many of his patients that went through breast cancer had pain, and there was nobody to deal with, nobody to treat them. So he's just like, I'm just starting my own pain clinic. And that's how this pain clinic started 25 years ago. So, unfortunately there's a gap, but hopefully things will improve. But there's a lot of people living with chronic cancer. related pain. Not a specific statistic, I'm sorry, but we know we need to do better.
Yeah, thank you so much for your transparency. And also, so we have two more questions in the live chat. So the first one is, what type of pain is associated typically with CLL?
Oh gosh. It could be, depends on if your CLL is under control, if you're having a flare, or you could have bone pain. Probably more like musculoskeletal and bone pain associated with CLL. It depends on the different treatments that you might be on. I don't know if some of the treatments can cause neuropathies. I'm not familiar with right now what the most common treatments are for CLL. The treatments are always changing and evolving. But generally with CLL, the patients that I've met, we don't actually see a lot of patients with CLL in our cancer pain clinic. So but musculoskeletal sort of bone pain type of pains would be the more common, and treating those things with the medications would be more of like acetaminophen and things like that, and sort of heat and cold and some physiotherapy and things like that. So you're not going to be treating those types of pains with the high impact things like opioids and things like that.
Thank you so much for that answer. And then our last question for today's session is, how will I know when it's time to request a referral to the pain clinic? This individual is 3 months in remission, but still experiencing bone and muscle pain, and they are also participating in rehabilitation.
Yeah, I mean, you could request a referral now if you think, that just to sort of make sure you're getting on the right track. Maybe you get in, and by the time you get the referral in and then you get seen, it might be some weeks anyway, depending on the resources in your area. So it doesn't hurt to sort of just make sure that everything is sort of optimized, and that there aren't some things that haven't been explored. So it doesn't hurt just to ask for that referral and have that assessment if that individual is willing and wants to connect. It feels like they need to connect with a specialized pain team.
Perfect. Thank you so much, Jocelyn. And before we wrap up, I'm going to ask that you switch to the slide after the last one that you had presented. And we'll do our wrap up for the day and discuss some of the resources that are available at the LLSC, in addition to some of our upcoming conference sessions. So as I mentioned before we sign off today, I'd like to mention that we have 4 more presentations being offered in our Your Life After Cancer conference series. So our upcoming events this week, later today, we have Managing Fear of Cancer Recurrence at 3 o'clock Eastern Standard Time. We have upcoming Cancer and Work, Tools and Resources to Help and Support You. That's on June 15th. Surviving and Thriving with and Beyond Cancer, a Guide to Rebuilding Your Life, also on June 15th. And Living Well with and Beyond Cancer, the Vital Role of Physical Activity, on June 16th. Please visit bloodcancers.ca to learn more about these conference sessions and to register for all of those in which you are interested in. Next slide, please. We would also like to thank Kite, a Gilead company, and Pfizer for making the Your Life After Cancer conference possible today. Next slide. And finally, remember that we are here for you every step of the way. You can reach us by email or by visiting our website, bloodcancers.ca, or by calling toll-free at 1-833-222-4884. Please note that a short survey will also be sent to all participants after this presentation. If you could please take a moment to respond and help us to plan the best events for you possible in the near future, they would be much appreciated. Thank you for being here with us, and please take good care of yourself.
Thank you.